Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist for more than 40 years in Houston. In this presentation, we're going to look at the 2D echocardiogram views and structures. What are the different views we use to record the 2D echocardiogram and also the Doppler studies, and what are the structures we see when the transducer is placed in a certain position. There are 4 or 5 main positions where the transducer is placed, and in special occasions, the transducer can be placed in multiple locations and different angulations, looking at almost every structure in the heart, from the heart chambers to pulmonary arteries or pulmonary veins and the vena cava, all kinds of structures. So let us begin with the main presentation. The main views that we use in recording echocardiogram and Doppler studies, we start off with the parasternal long axis, where the transducer beam is going this way across from the right shoulder down, and that's what we see here, the longitudinal parasternal long axis. Then we have the short axis, which is sort of cutting through the heart chamber, giving you the short axis of the right and the left ventricles. The third most commonly used, from the apex, we use the transducer going up this way, which looks at the heart chambers from the tip all the way to the base of the heart. That's giving you the right ventricle, the left ventricle, and the left atrium and the right atrium in a 4-chamber view. So these are the main angles we use. Then we have the 3-chamber view, we have the 2-chamber view, we have the 5-chamber view. Then we have the short axis when it is angulated more towards the aorta. We get the aorta and the left atrial view, and when we go towards the apex, we get the apical view where we can look at the papillary muscles. So there are various angulations and permutations that can be done to look at practically every structure in the heart, including the left atrial appendage. Of course, 2D echo is limited in terms of analyzing the left atrial appendage, but it's something which can be done better using the transesophageal echocardiography. But we're going to focus on 2-dimensional echocardiography because this is the basic study that every cardiology fellow needs to understand before you go into more sophisticated imaging process. So just to get sort of an orientation for the first time, if you're doing this, you can follow this bright green arrow. And here is the 4-chamber view. And here we have the left ventricle. How do we know this is the left ventricle? The thickness of the muscle is almost 2 times that of the right ventricle. That's one way to look at it. Then we have the mitral valve here. We have the tricuspid valve, the right atrium and the left atrium. Sometimes we can see pulmonary veins here. So that is the 4-chamber view. But the most common view we start off is known as the parasternal long axis, where we have the right ventricle here. And this is the aorta with the aortic leaflets. This is the interventricular septum. We have the anterior mitral leaflets. We have the posterior mitral leaflet, which is kind of almost tethered to the posterior wall. Then we have the posterior left ventricular wall, and this brighter echo is the epicardium. Epicardium is an important structure which separates the heart from the lungs. So if you have a pericardial effusion, it should stop somewhere here at the coronary sinus, whereas pleural effusion can go beyond the pericardial shadow above the coronary sinus. So those are some finer points. And here we have the left atrium. So what we're going to do is taking this basic anatomy into consideration, let's dig a little deeper and look at each one of these angles and the structures we see, so you get a quick crash course on views and structures. And this is a short axis here, and of course this is like the more or less 2 or 3 chamber view. We have the left ventricle, the mitral leaflets, the left atrium, and perhaps this is the aorta. We see a similar three-chamber view in a longitudinal section, but this is taken from the apex of the heart. And here's the short axis showing the left ventricular cross section of the left ventricle. We don't see the right ventricle, and here are the papillary muscles. We'll exactly know every structure and the anatomic name of each one of these sectors in the next several slides. So let us start off with the first parasternal long axis, and I just went through this briefly. And here we have the right ventricular wall, we have the right ventricular cavity, interventricular septum, then we have the aorta, we have the aortic leaflets, we have the right coronary cusp and the non-coronary cusp. It is exceedingly important for you, if you are taking board exams, to know what cusp you are talking about. Aorta has three leaf cusps, namely the right coronary cusp, the left coronary cusp, and the non-coronary cusp. And here you have to identify this is the right coronary cusp and non-coronary cusp in the parasternal long axis view. That's the aorta, and we can look at calcification of the valves and all these other features. We're just going to go through normal anatomy at this time. And here's the anterior mitral leaflet. I hope you can see my arrow. Here's the anterior mitral leaflet. Here's the posterior mitral leaflet. This is the left ventricular cavity. Again, this is a posterior ventricular wall, and here's the epicardium, and this is the descending thoracic aorta, and it is outside the pericardial lining. And if you look at some like darker shadow, that could be the coronary sinus. And if you get a pericardial effusion, it's going to be within the epicardial layer between the epicardium and the pericardium. Okay, so those are the structures we see here, and we could be seeing this in diastole or systole depending upon when the frame was obtained. Let's move on to the next one, parasternal short axis, which is a very commonly used one, starting off at the mid-level, looking at the left ventricle. And here we have, where's my arrow? Here we have the anterior wall, here we have the septum, here we have the inferior wall, and here we have the lateral wall, and this is the left ventricular cavity and the papillary muscles. Posterolateral, posteromedial papillary muscle and the anterolateral papillary muscle. Keep in mind these anatomic structure identifications are of great importance because they could be on your board exam. So similarly, this is the apical view of the cavity, looking at the short apex with increased thickness of the left ventricular muscle as we approach the apex of the ventricle. Now let's move on to the subcostal four-chamber view. This is the last view we generally do, but anyway, this is in this sequence here, so we might as well talk about it. Okay, and here we first thing we see is the one closest to the transducer is the right ventricular cavity. We have the interventricular septum. We see the left ventricle and the mitral leaflets. The left atrium is farther away from the transducer. We have the right atrium. One of the good things about is we can use Doppler to look for any evidence of right to left or left to right shunt in this particular view. It is exceedingly useful in identifying the presence of atrioseptal defects or even atrioseptal defects or the ventricular septal defects, and we can also detect the presence of like left atrial myxoma or other structural abnormalities. Now if you come over here, right ventricular inflow view. When the transducer is in a parasternal long axis, it is focused towards the left ventricle and the right shoulder. And if we just turn it a little bit to the right side, we're going to see the right ventricular cavity, we're going to see the right atrium, and by angling a little bit posteriorly, we can see the superior vena cava and the inferior vena cava. And this is not an easy angle to get, but it's going to take a lot of practice to get to this view. And this view would be quite useful in identifying the presence of significantly elevated pressures where the vena cava may be dilated and may fail to show inspiratory changes of greater than 50%. Now we have the apical four-chamber view, which is a very commonly used view, and of course some places they flip this image where the left ventricle is on the right and the right is on the left, but normally the left ventricle is on the right side and the left ventricle is on the right side and the right ventricle is on the left side. And we can also say that by looking at the thickness of the wall, which will be much thicker on the left side. Then we have the left ventricular cavity. We have the lateral wall here. We have the interventricular septum. We have the mitral leaflets. As you can see, this is the anterior leaflet. This is the posterior mitral leaflet. And remember, there are three mitral leaflets, the anterior, posterior, and the lateral leaflets. There are three leaflets, and there are scallops, I should say. And that's something we have to, mitral has, and here is the left atrium, and here's the descending thoracic aorta, interatrial septum, which is generally, more often than not, looks like a dropped shadow. That's because the beam is going parallel to the wall and the septum is very thin. Right atrium, then we have the right ventricle, and this is the crux of the heart. If you come to the inferior vena cava long axis, this is when the transducer is sort of angled towards the abdominal cavity close to the liver, and that's when we can see the liver here and we see the inferior vena cava. And this is helpful in patients with heart failure with elevated venous pressure and in patients with cardiac tamponade to look for any evidence of collapsible inferior vena cava. If the inferior vena cava is greater than 2 centimeters and it doesn't collapse during respiratory cycles, it may suggest significantly elevated intracardiac pressures. Let's move on. Right ventricular outflow tract. Right ventricular outflow tract is where, again, the transducer is angled just a little bit towards the right side, in a parasternal long axis, where we see the right ventricular cavity, and then we see the pulmonary artery, and here is the pulmonic valve. Now we have the apical five-chamber view. The apical five-chamber view, when we are looking at the chambers, it is a little bit posterior, but look at posterior. When the transducer is just lifted up a little bit, now it is going to come anteriorly. Now the structures that come into focus will be the four chambers plus also the aorta, and that's what we are seeing here. We see the right ventricle here, the left ventricle, and of course the mitral leaflets here, the left atrium, and here we see the aorta now, which is the fifth chamber, along with the aortic leaflets here. So that's the five-chamber view. Now we're going to go to the subcostal view. Subcostal view is for looking for the abdominal aorta, for any evidence of abdominal aortic aneurysms, and also looking at pulsations. And it is done in a manner similar to the subcostal view, except the beam is directed directly towards the spinal column to look for the aorta, and by using Doppler we can identify the blood flow in the aorta, thus identifying the structure. Next we move on to the parasternal short axis at the aortic valve level. Here we see the aorta, which is like a circle with a Mercedes-Benz sign, and there you need to know what are these leaflets. This is the anterior leaflets. This is the right coronary cusp. This is the left coronary cusp. This is the left atrium. And here we have the right atrium, and we have the right ventricular outflow tract here, and maybe some main pulmonary artery. But as you can see here, we have what is known as the right coronary cusp. Right coronary artery comes from the anterior cusp, or the right coronary cusp. This is the left coronary cusp, and this is the non-coronary cusp. And you need to memorize this anatomy if you're taking a board exam. In a short axis, the anterior is, because the right coronary artery comes right from the front, and it traverses to the right side in the right atrioventricular groove. Let's move on to apical two-chamber view, where we see the left ventricle and the left atrium along with the mitral leaflets. Of course, we know these mitral leaflets and the atrium, but here you need to know which part of the left ventricle is this covering. As you can see, this is covering the inferior wall, whereas this is covering the anteroseptal region, anterior wall of the septum. And here we have the left atrial appendage, which we can see, but that's not the view actually we use to really rule out any left atrial appendage clots. And here we have the posterior leaflet of the mitral valve, which you can see, and this anterior leaflet. And of course, behind that, we see the abdominal aorta. Now let's move on to the suprasternal notch. Suprasternal notch is where you place a transducer, preferably like a peed-off transducer with that small black rounded top, and this is where you can angle it towards the right side where you're going to see the ascending aorta, or towards the left side where you're going to see the descending thoracic aorta. This is very useful in patients with aortic stenosis, looking for gradient across the aortic valve, and you can also look at the blood flow through the aorta itself. You may also be able to detect some presence of coarctation of the aorta, which may show up in this region. And here we have the ascending aorta, we have the aortic arch here, and the descending thoracic aorta, and these are the common carotid arteries. Then we have the left main bronchus here, the air-filled bronchus. Then we have the right pulmonary artery just close to that. And behind that is the left atrium. We got one more picture here to cover, and that is the mitral valve level of in the short axis. We can go all the way from the tip of the heart all the way to the base of the heart and the main blood vessels like the pulmonary artery, aorta, left atrium, and other things. But in the midsection, we see the mitral valve leaflets, the anterior mitral valve leaflet, and here we have the posterior mitral valve leaflet. We can also look at the papillary muscles. We already talked about that. We have the anterolateral papillary muscle, and here we have the posteromedial papillary muscle, which we are not seeing here. But anyway, so this is the anterior mitral leaflet, which is much larger than the posterior leaflet. We generally see the movement of the anterior leaflets more visible than the posterior leaflet, which kind of just provides the support for the anterior leaflet to come in approximation. Here we have the right ventricular cavity. We can look at wall motion abnormalities. We can look at chamber size, look at ejection fraction, look at pericardial effusion, and a whole host of things. We can also do a stress echocardiography and look at regional wall motions related to the stress. And finally, we coming up with two more pictures here. Apical three-chamber view. This is a very common view which is generally done. I was certified to do echocardiography in my practice. I did echocardiography for more than 35 years in my office because I had a beautiful HP Dimension 8 echo machine, and I loved doing echocardiography. And here we have the interventricular septum. Remember, this is the interventricular septum, and we need to know what part of the left ventricle we are looking at various angles. Then here we have the inferolateral part of the segment, and here we have the posterior leaflets, then the anterior leaflets, the aortic leaflets, left atrium. And just to go back to the orientation of interventricular septum, anteroseptal versus the inferopostal, let me go back to this picture short axis here. As you can see, the anterior septum is this one, and when you're looking at the anterior septum, you come here, you're looking at the inferolateral part of the ventricle. That is because this is going through this way. If you're going through this way with a parasternal long axis, you're going through the anterior wall and the posterior wall. Whereas with the four-chamber view, you're going through the septum and the lateral wall. These are exceedingly important points to bear in mind because you need to train your brain to have a three-dimensional view of the heart as you would normally see if you open up the chest. But the beauty of transducer is you can do that without opening up the chest, just with these angulations and variations in the views. So keep in mind, here we have the anterior wall, we have the anteroseptal, here we have the infralateral, the opposing walls, then we have the septum and the lateral wall. So these are extremely important depending upon whether you're looking at the two-chamber view, three-chamber view, or long axis or short axis. So ladies and gentlemen, this is a very quick synopsis of various echocardiographic views and the anatomic structures related to them. And once you learn this, memorize this, make it internal to your system, it should come as second nature every time you place a transducer. Okay, oh, that is the aorta, oh, that's the left atrium, those are the anterior leaflets, those are the posterior leaflets, that's the papillary muscle, this is the anterior wall, this is the lateral wall, that's the pericardial effusion, no, this is a pleural effusion. You should be able to tell that by just looking at the pictures. Thank you so much for watching. We have more than 250 presentations on various cardiology topics. Please do watch them, and please do subscribe to our YouTube channel. I will see you in the next presentation. Have a wonderful day.